Hello and welcome to the topic Scleroderma in the Rheumatology module. By the end of this topic, you should be able to define scleroderma, discuss the epidemiology of scleroderma, outline the pathophysiology and the causes, outline the classification of scleroderma, describe the clinical manifestations, outline the investigations that are carried out, and finally discuss the principles of management and complications of scleroderma. Let's get started. Scleroderma, also known as systemic sclerosis, is a multisystem autoimmune connective tissue disease characterized by functional and structural abnormalities of the small vessels causing fibrosis of the skin and internal organs due to the production of autoantibodies. There are two main types of scleroderma, namely limited cutaneous scleroderma and diffuse cutaneous scleroderma. The prevalence of scleroderma in the US is higher than in Europe or Asia. Scleroderma is more common in women than men with a ratio of 5:1. The disease is rare in childhood, but more common in young adults, especially during childbearing age, and most common at the age of onset 30 to 50 years old. In general, inflammation is a multi-step process triggered by causes and agents that result in acute or chronic inflammation. This inflammation will trigger host response, which includes cell recruitment, adaptations of the vasculature, and changes of the tissue composition as well as extracellular matrix. In scleroderma, vascular injury activates endothelial cell and immune system. The endothelial cells release endothelin-1 to cause vasoconstriction, whereas the triggered immune system will activate T cells. Activated T cells release cytokines such as tumor growth factor B, interleukin-1, interleukin-4, interleukin-6, leukotrienes B4, and type 1 interferon. Both activated endothelial cell and immune system activate fibroblasts, which will overproduce collagen, enhance proliferation, matrix, and synthetic function. These cause collagen and connective tissue accumulation, reorganization, and impaired degradation of extracellular matrix and contraction. All these processes will then result in tissue fibrosis. The causes of scleroderma include gene polymorphisms such as HLA complex, IRF5. The causes of scleroderma include gene polymorphism. Immunology and environmental causes such as exposure to silica dust, multiple solvent exposure, and viral or bacterial infection are among other causes. More than 90% of scleroderma patients have positive ANA, anti-topoisomerase, anti-RNA polymerase III, and anti-centromere. Now we will discuss the two classifications of scleroderma, namely Leroy classification and the ACR-EULAR classification. Leroy classification classifies scleroderma according to the extent of involvement. Patients with diffuse cutaneous systemic sclerosis will have tight skin thickening that involve proximal extremities or the trunk or even face and distal extremities. Limited cutaneous systemic sclerosis have skin thickening that is confined to sites distal to the elbows and knees but can also involve the face. Sign scleroderma has characteristic internal organ involvement along with vascular and serological abnormalities without clinically detectable skin thickening. The ACR and EULAR classification is the criteria used to diagnose scleroderma. A total score of more than 9 is confirmed diagnosis of scleroderma. 6 to 8 points is probable scleroderma and less than 6 points is unlikely to be scleroderma. The criteria include skin thickening of the fingers, fingertip lesions, telangiectasia, abnormal nail fold capillaries, pulmonary arterial hypertension or interstitial lung disease, Raynaud's phenomenon, and scleroderma-related antibodies. Now let's discuss the clinical manifestations of scleroderma. In general, patients may have positive family history of other connective tissue disease, and complain of fatigue or reduced effort tolerance. A lot of patients will complain of hand symptoms such as swelling, stiffness, skin tightness, cold bluish fingers, which is seen in Raynaud's phenomenon, digital pits, or ulcers. Gastrointestinal symptoms are present such as heartburn, reflux, dysphagia, bloating, distension, constipation, and melena. Melena can happen due to gastric antral vascular ectasia. Musculoskeletal complaints such as myalgia, arthralgia, weakness may also present in patients with scleroderma. Patients with respiratory complications may experience dry cough or dyspnea, and this is secondary to interstitial lung disease. Classical signs of scleroderma include Raynaud's phenomenon, digital pits, ulcers, telangiectasia, sclerodactyly, microsomia, subcutaneous calcinosis, and synovitis. These pictures show the clinical manifestations of scleroderma. There are some signs of complications such as pulmonary arterial hypertension, which may present with loud and palpable second heart sound, interstitial lung disease, which may show dry, fine crackles, signs of arthritis, and malignant hypertension in scleroderma renal crisis. Let's discuss the investigations of systemic sclerosis. Autoantibody testing is the diagnostic test for scleroderma. More than 90% of patients have positive ANA. About 20% of patients may show positive anti-topoisomerase or anti-SCL70. Anti-topoisomerase antibodies are associated with risk of interstitial lung disease. Anti-RNA polymerase III is also present in about 20% of patients, and it is associated with risk of renal crisis. Anti-centromere antibodies, which are present in about 20 to 25% of patients, are associated with limited skin involvement and have better prognosis. Investigations that can assess the severity of scleroderma include a full blood count, urea and creatinine, and urine analysis with microscopy. A full blood count may show results of anemia due to chronic GI bleed in GAVE or show picture of microangiopathic hemolytic anemia in renal crisis. Urea and creatinine may be raised in renal crisis, while urine analysis and microscopy may show mild proteinuria or cast in renal crisis. The exclusion tests of scleroderma include imaging such as X-rays, CT scans, MRIs, and ultrasound. X-rays and CT scan can help to exclude bony lesions and arthritis. MRI and ultrasound can be done as soft tissue examination. Now, this slide discusses the prognostication tests and secondary prevention investigations for scleroderma. ESR and CRP levels can be high but indicate poorer prognosis. A pulmonary function test can be done to evaluate restrictive lung disease and pulmonary hypertension. Interstitial lung disease will show low forced vital capacity and a restrictive pattern, while pulmonary hypertension may depict a disproportionate drop in DLCO compared to a forced vital capacity. To assess cardiac involvement and arrhythmias, an ECG and an echocardiogram can be done. Physicians can also request for a barium swallow to assess dysmotility, reflux, and strictures. If GAVE is suspected, an upper GI endoscopy should be done. Let's discuss the principles of management of scleroderma. Let's begin with symptomatic relief. NSAIDs can be ordered for patients to manage pain. Patients with Raynaud's phenomenon can be treated with lifestyle changes such as avoidance of cold exposure, hand exercise, and stop smoking. Wound care as well as analgesia can be helpful too. If these therapies have failed, physicians should consider adding a phosphodiesterase 5 inhibitor, calcium channel blockers, or topical nitrates. Emollients can relieve itchy dry skin. Cyclophosphamide can treat skin thickening. Low-dose glucocorticoids can be used for pruritus and stiffness. Patients with GI symptoms such as gastroesophageal reflux disease should be advised for lifestyle changes such as avoiding eating 2 to 3 hours prior to bed, avoid caffeine and carbonated drinks, as well as elevate heat after meals. Patients with intestinal dysfunction should be given prokinetic agents such as erythromycin and octiotride. There's no specific treatment for scleroderma. Physicians usually manage the symptoms and complications. Scleroderma patients who have pericardial effusion can be given oral prednisolone, while pericardial window or systemic corticosteroids can be offered if cardiac tamponade is present. The progression of scleroderma can be delayed by treating the associated complications. Measures can be taken as secondary prevention, which improve strength, maintain mobility, and minimize joint contractures. Let's quickly take a look at the complications of scleroderma. The short-term complications include digital infarction, skin infection, and osteomyelitis. Since scleroderma is a systemic disease, the long-term complications may involve most of the important systems. Respiratory complications include interstitial lung disease, pulmonary hypertension, and aspiration pneumonia. Musculoskeletal complications include myositis, and renal complications include renal crisis and renal failure. Hypothyroidism, particularly Hashimoto's, and Sjögren's syndrome are endocrine-related complications. GI complications include malabsorption, esophageal stricture, Barrett's esophagus, while cardiovascular complications are arrhythmias, cardiomegaly, and heart failure. Scleroderma is treated with immunotherapy, and there are few drug-induced complications such as methotrexate, which can induce liver fibrosis and hypersensitivity pneumonitis, cyclophosphamide causing neutropenia, hemorrhagic cystitis, and infertility. In summary, scleroderma, also known as systemic sclerosis, is a multisystem autoimmune connective tissue disease characterized by functional and structural abnormalities of small vessels, which include fibrosis of the skin and internal organs caused by production of autoantibodies. Scleroderma can be divided into the limited and diffuse cutaneous systemic sclerosis. Women are more commonly affected compared to men, and most common age range is between 30 to 50 years old. We can use the Leroy classification to classify scleroderma into diffuse and limited, while ACR or Euler classification is the diagnostic criteria. Clinical signs include Raynaud's phenomenon, sclerodactyly, telangiectasia, digital infarction, microsomia, as well as interstitial lung disease lung findings. The autoantibodies include ANA, anti-topoisomerase, anti-RNA polymerase III, and anti-centromere. There's no specific treatment to cure scleroderma. The principal management includes managing the symptoms and complications. The complications of scleroderma include pulmonary, myositis, renal crisis, hypothyroidism, GI complications, as well as cardiovascular complications, among others. We have come to the end of this topic. Thank you.